A very good afternoon, everyone. I welcome you all to the webinar series by Vijaya Diagnostic Center. I'm Dr. Divya Raju Alluri, a consultant radiologist at Hemalatha branch. Today, our topic of discussion in this webinar series is endometriosis, which is an increasingly prevalent gynecological condition affecting an estimated 10% of the women of the reproductive age. It can be an extremely debilitating time for the women and can worsen with time. Hence, the importance of making a proper diagnosis early so that the appropriate management may be started as early as possible. For this, a proper understanding of this condition with the correlation of our radiological findings with the clinical picture is imperative. Today, our speaker, Dr. Hemalatha SR, will be addressing this in her presentation on Clinilcoradiological evaluation of endometriosis. And today, joining us in this webinar as the chief guest will be Dr. M.L. Avani, who will share her valuable clinical experience pertaining to endometriosis. Dr. Avani finished her MS in 2008, followed by a fellowship in reproductive medicine, IMA 2015, and also a diploma in reproductive medicine from Kiel, Germany in the year 2017. She worked as a consultant at Surya Fertility Center in Banjara Hills from 2012 to 2017. And she has been working at Apollo Hospitals as a fertility consultant from 2018 till date. And our speaker for today, Dr. Hemalatha, who's a consultant at our Vijaya Diagnostic Center, finished MBBS from Sri Venkateshwara Medical College, Tirupati. She did her MD from 2014 to 2017 at Narayana Medical College, Nellore. Then she finished her DNB in 2019 and EdiR in 2022. She has been working in Vijaya since March 2023. However, prior to this, she worked as a consultant at ESIC Medical College, Sanat Nagar, Hyderabad from 2017 to 2021. And she also served in the same place as the assistant professor from 2021 till she joined Vijaya. So, Dr. Hemalatha, over to you. You can present.
Thank you, Divya ma'am. Thank you, Avani ma'am, for joining us. I'd like to express my gratitude for Kishore sir and Vijaya Diagnostic Center for providing me this opportunity. I'm going to talk about clinico-radiological evaluation of endometriosis. My screen visible, ma'am?
Yes.
Yes, thank you, ma'am.
No. Actually, no, it just went again. Screen is not. 1 second. Screen is not. Oh, okay. Done.
Thank you, ma'am. Endometriosis is a chronic gynecological disorder that is characterized by the growth of endometrial tissue and stromal contents outside the uterine cavity, which primarily as implants in the pelvic peritoneum and ovaries. It is estrogen dependent and a complex inflammation process involving 5 to 10% of the population. The symptoms are severe dysmenorrhea, deep dyspareunia, chronic pelvic pain, as well as cyclical pain, ovulation pain, perimenstrual symptoms, and infertility. Chronic pelvic pain, infertility, and dyspareunia are considered as characteristic triad. When there is involvement of bladder, there will be cyclical hematuria and dysuria. The involvement of rectum and sigmoid may result in catamenial diarrhea and hematochezia. When there is lung involvement, it may result in hemoptysis, catamenial pneumothorax. Usual clinical examination findings are non-specific. There can be tenderness along the adnexa and uterosacral ligaments, pouch of Douglas. There may be associated thickening and nodularity of the pouch of Douglas. There can be rectovaginal as well as adnexal masses. Multiple theories has been proposed for the pathogenesis of endometriosis. There are Samson or metastatic theory, which states that there can be implantation due to retrograde menstrual flow, which is backed up by a immunological theory, which states that there can be immune dysfunction resulting in the non-clearance of retrograde menstrual flow. Another theory that has been proposed was metaplastic or Halban's theory, which states there can be coelomic differentiation of peritoneum that may result in development of endometrial stroma and glands. The endometriosis can manifest as either ovarian endometriosis or superficial peritoneal endometriosis, where there are implants on the surface of organs, or they can demonstrate a depth of less than 5 mm in the peritoneum. The third variant is deep pelvic endometriosis or deep infiltrative, where there is the extent to a depth of more than 5 mm of the peritoneum. The most common sites of endometriosis are ovaries, rectouterine pouch, and rectosigmoid colon. Usually, the diagnosis is established by the laparoscopy and histopathological examination. In view of invasiveness of this laparoscopy, the 2022 updated endometriosis guidelines from the European Society for Human Reproduction and Embryology guidelines now recommend imaging both ultrasound and MRI as frontline diagnostic tests. Transvaginal scan of pelvis is considered as primary line of investigation because of its cost efficacy and real time, whereas MRI is usually used as adjunct modality and as well as for mapping of the disease prior to the surgery. The usual protocol consists of T2 weighted imaging in two orthogonal planes, that is sagittal as well as axial, and T1 weighted sequences with and as well as without fat sat sequences. Contrast study is advised only when there is a suspicion for malignancy and for determining the extent of active deposits. Bowel preparation is usually mandatory for the MRI imaging, which includes oral laxative 1 day prior to the examination, fasting for 4 to 5 hours on the day of examination, and when there are more artifacts due to bowel movements, antispasmodic agent can be administered. Coming to the superficial endometriosis, it may appear either as red tiny nodules when there is active hemorrhage, or they may appear as white nodules due to fibrosis and inflammation. In chronic stages, because of hemosiderin deposition, they may appear brown or black, which is considered as powder burn appearance. Neither MRI or TVS are sensitive for the superficial endometriosis until the lesions are more than 5 mm with hemorrhagic contents. Only the hemorrhagic pigmented contents may appear as T1 weighted hyperintense signal, whereas when the lesions are non-pigmented, they are usually hypointense on T1 weighted sequences and hyperintense on T2 weighted sequences. These are the representative coronal T2 weighted and T1 fat sat images showing superficial implants as hyperintense foci. Ovarian endometriosis, it can manifest as either surface implants or micro intraovarian endometriomas, where there are multiple bilateral cystic lesions of less than 1 centimeter size, and they appear hyperintense on T1 weighted sequences and hypointense on T2 weighted images. The third one is endometriomas, which are also called as chocolate cysts because of their thick gelatinous contents. They develop when superficial endometriotic lesions on the surface of ovary invaginate into the stroma. Due to repeated cyclical hemorrhage, the pseudocyst will form with a thick fibrous wall. These lesions are usually bilateral and multilocular. In ultrasound, they appear as thick walled cystic lesions with diffuse uniform ground glass like internal echoes. There will be no color flow on the within the lesions. During pregnancy, they may undergo desexualization. Because of peritoneal adhesions, these ovaries may displace posteriorly and may become fused to each other behind the uterus, where the term kissing ovaries is used. This is a transvaginal image showing endometriomas in both ovaries, with ovaries being fused to each other and behind the uterus. On MRI, endometriomas will show bright signal on T1 weighted images, which will become more conspicuous on T1 fat sat images, resulting in light bulb sign. In T2 weighted sequences, usually we see gradual loss of signal loss to the dependent portion because of the differential age of the degradation products, which is referred to as T2 shading sign, that is characteristic of endometriomas on MR imaging. Sometimes we can see the hematocrit levels, that is fluid levels. The main differentials for the endometriomas are the lesions which appear bright on T1 weighted sequences, that are blood containing lesions like hemorrhagic cysts, dermoid cysts, which may show loss of signal on T1 weighted fat sequences, and mucinous cystadenocarcinoma. But the brightness of mucinous cystadenocarcinoma will be usually less than the fat. The main differential will be the hemorrhagic cyst, which is usually small unilocular and thin-walled lesions. They are not homogeneously hyperintense as compared to the endometriomas, and there will be no T2 shading, and they doesn't show any enhancement, whereas endometriomas show peripheral enhancement. Coming to the third variant, deep infiltrative endometriosis, where there will be subperitoneal invasion of more than 5 mm into the peritoneum. They contain endometrial glands and stroma accompanied by hemorrhage, fibrous, and adhesions. These glands and stroma infiltrate the adjacent fibromuscular tissue and elicit a smooth muscle proliferation and fibrous reaction, resulting in the nodule formation. It may affect the fibromuscular pelvic structures like rectovaginal septum, vesicovaginal septum, uterosacral ligaments, gastrointestinal system, urinary tract, and extraperitoneal sites like diaphragm and lungs. The imaging morphology dependent on the contents of the nodule. If there are predominantly glandular components that are cystic, they will appear hypointense on T1 weighted sequences and hyperintense on T2 weighted sequence. When there are hemorrhagic contents in these cysts, they will appear hyperintense on T1 weighted sequences and hypointense on T2 weighted imaging. The fibrous components may appear either linear or stellate in appearance, and they are usually uniformly hypointense to skeletal muscle on T2 weighted imaging. For deep pelvic endometriosis, three-compartmental approach has been proposed for proper evaluation and detailed reporting. The pelvis has been divided into anterior, middle, and posterior compartment. Anterior compartment consists of prevesical space, vesicouterine space, urinary bladder, vegecovaginal septum, urethra, and distal ureters. The middle compartment will consist of uterus, fallopian tubes, ovaries, broad ligaments, vagina. Posterior compartment will consist of pouch of Douglas superiorly and rectovaginal septum inferiorly, which is actually extraperitoneal space, rectosigmoid colon, presacral space. Bladder is the most commonly involved organ in the anterior compartment apart from the vegecovaginal septum. The bladder endometriosis is defined when there is full thickness invasion of detrusure due to subperitoneal implants. When we see only small nodules on vesicouterine fold, it is not considered as bladder endometriosis. We have to label that as superficial peritoneal endometriosis. Bladder endometriosis morphology depends on the nodular formations, which show typical adherence to the anterior uterine surface and form obtuse angle with the urinary bladder. On ultrasound, they appear as solid hypoechoic nodule that may show either regular or irregular margins. This is the 3D transvaginal scan showing the nodule that is indenting into the lumen of the urinary bladder. On MRI, these lesions show isointense signal. This is the oblique coronal T2 weighted and T1 sagittal T1 weighted fat sat images showing a nodular lesion that is isointense to the bladder wall. In T1 fat sat images, we can see tiny hyperintense foci that are hemorrhagic contents, and these lesions may show delayed enhancement due to their fibrous component. The next organ that is involved in anterior compartment is ureters. Urethral endometriosis is defined as compression or distortion of normal urethral anatomy due to deep pelvic endometriosis with or without presentation of hydroureteronephrosis. It is divided into two types: extrinsic when there is only serosal infiltration, and intrinsic if there is muscle invasion that will result in strictures and luminal narrowing, thereby resulting in hydroureteronephrosis. Most commonly, the left ureter is involved due to inhibited flow of peritoneal fluid by the sigmoid colon. This is the axial T2 and sagittal T2 images showing a speculated periurethral hypointense lesion that is resulting in narrowing of ureter and upstream dilatation of the ureter. In the patients with endometriosis, it is advised annual serum creatinine evaluation because there can be slow renal impairment. Fallopian tube endometriosis may present either as hydrosalpinx when there are serogel implants that will result in peritubular adhesions and fibrosis, or when there are implants within the lumen, it may present as hematosalpinx with hemorrhagic contents. Hydrosalpinx will appear as hypoechoic tubular structures, and because of the submucosal plicae, they may show the cogwheel appearance on the ultrasound. Whereas in MRI, they will appear hypointense on T1 weighted imaging and hyperintense on T2 weighted sequences. In hematosalpinx, because of the hemorrhagic contents, they will appear bright during T1 weighted sequences and again also on T2 weighted sequences. Sometimes they may demonstrate hematocrit level, but they will never, and the cogwheel appearance. Pouch of Douglas is the deep peritoneal pouch situated between a bilateral rectouterine folds, and it is the most inferior part of the peritoneal cavity, and is the most commonly involved part of the posterior compartment of the pelvis. In ultrasound, pouch of Douglas involvement is evaluated by sliding sign, which is usually modified, and the pressure is usually applied on the uterine fundus, and relative movement of the rectum is assessed. MR imaging features of pouch of Douglas involvement include: there will be persistent uterine retroflexion. These are the sagittal T2 weighted images representing the pouch of Douglas endometriosis, where we can see the retroflexion of the uterus, fibrous plaque, tethering of the intestine, fibrous strands, and there is elevation of the posterior vaginal fornix. Vagicovaginal and rectovaginal septum endometriosis will appear as ill-defined hypointense infiltrative tissue or nodule on T2 weighted sequences. These are the sagittal and axial representative images where we can see the hypointense nodular tissue in the vagicovaginal septum, and in the rectovaginal septum, few tiny hypointense foci representing glands are present within this tissue. In the GI tract, rectosigmoid colon is the most commonly affected part, followed by appendix and terminal ileum. On ultrasound, these lesions are usually seen as solid homogeneously echogenic nodules that are attached to the intestinal wall with irregular contours. On MRI, they appear as hypointense, well-defined lesions. These lesions show pyramid-like appearance with base towards the intestinal wall, and they involve the intestine from 10 to 2 o'clock position, and the apex will be directed towards the cervix. When there is invasion of muscularis propria, there will be differential growth along the vertical component, and there will be predominantly endophytic growth, which will result in the mushroom capsine. Uterosacral ligaments are thin fibrous bands which extend from the torus uterinus dorsocranially to the sacrum. There can be unilateral or bilateral involvement which appear as asymmetry of the ligaments, focal thickening, or nodule with regular or stellate margins. These are the axial, tituated, and sagittal images of a 35-year-old patient with endometriosis, where we can see the focal thickening of the uterosacral ligaments and its stellate appearance. Diaphragmatic endometriosis is very rare, affecting only 5% of the population affected with endometriosis. It typically manifests as nodules that show hyperintense signal on both T1 weighted images, T2 weighted images, and T1 fat sat sequences. Other extraperitoneal involvement will be in the lung, where the imaging findings will be non-specific, like ground glass opacities or tiny nodular opacities. It can also may manifest as thin-walled cavities. Pulmonary endometriosis is more common on right side. because of transcelomic spread along the right paracolic gutter. The other rare endometriosis type is scar endometriosis, which occurs due to direct implantation during the obstetric and gynecological surgeries. It may have either subcutaneous or muscular component, or it can be both subcutaneous and muscular components, usually associated with cesarean section scar and episiotomy scar. On ultrasound, these lesions appear as hypoechoic lesions with spiculated margins, and they show cyclical variation in their sizes. On MRI, they appear as hypointense nodular lesions with spiculated margins, and they are usually hypointense on both T2 weighted as well as T1 weighted images. There can be delayed enhancement of the fibrous component, and glandular component enhancement can be seen on post contrast study. These are my references. Thank you, ma'am.
Thank you so much, Dr. Hemlatha, for your comprehensive coverage of the topic. It was nice to see endometriosis covered in all aspects. That was very not very long, not very short. It was really engaging and informative. Thank you so much once again.
Thank you, ma'am.
I now invite our chief guest, Dr. Avani, to please take over and give you a valuable, insight into this topic. Oh, I can't hear you. No, no. Krishna, madam, the voice. He's asking you to rejoin, Dr. Avani. I think there's something wrong with the audio. Madam, ఒక్కటే వినపడట్లేదు వాల్యూమా తీసేశారు నాకు.
Can you hear me now?
Yes, ma'am.
You can? Yeah. So, good evening, everyone. It's a pleasure to be at this platform. And as we all know, the any case of endometriosis is very difficult for the treating doctor as well as the patient because it's an ongoing disease and there is no permanent solution for it unless and until she stops menstruating. So, coming to the general public, first it starts when they start the menstruation, like at menarche, when they're adolescent. So, we see in Asia around 20% of kids or adolescent teenagers having this severe dysmenorrhea. So the symptoms in adolescent is entirely different from the reproductive age group, where they have moderate to severe dysmenorrhea. In between the cycle, they have pain, they have urinary symptoms, they have gastric symptoms, where it becomes very difficult to diagnose the endometriosis early. So in adolescents, almost whoever has dysmenorrhea, 20% they have endometriosis. So early if we diagnose, we can treat them at least from their symptoms. So I just wanted to ask you, what would you prefer, the mode of diagnosis in an adolescent girl where we can't do a tvs? Would you want to do an ultrasound or an mri? In your experience, which is better?
Dr. Hemlata, would you like to say something?
Yes, ma'am.
Like if we can keep it interactive so that whoever the common questions who the doctors have, it can be cleared.
Yes, yes.
The common practical problems which doctors face.
Yeah. I think ideally, like me, in my experience in Vijaya, when very young, girls come with, they were firstly the whole differentiating factor between endometriosis and even hemorrhagic cyst. There's a slight radiological confusion regarding that also. So
Yes,
usually,
yes,
what I have
absolutely.
seen, yeah. So what I have seen personally is like Firstly, radiologically and sonologically, I think a hemorrhagic cyst shows much more internal septations, many more, and it creates a fishnet, pattern, a reticular pattern, sonologically, which we call, and it's predominantly cystic. But when it comes to an endometriotic cyst or a chocolate cyst, I think it gives, because of the solid, the diffuse thick echoes, it moreover gives a solid appearance.
Yeah.
So what I have seen is, initially when I see a cyst which is not too big and it is showing features of both, I usually ask for a follow-up scan, because hemorrhagic is likely to, probably if it's a functional cyst, let's say 3
It's going
centimeter,
to
maybe,
come down.
yeah, it will come down. Usually they tend to rupture. But
Yes.
in the case of endometriotic cyst, it usually tends to increase in size, or preferably maybe even
The
stay
same
stable.
size.
Yeah. So then, if it's very large and if it's an ongoing thing, and if it is really, involving in as a predominant factor causing infertility, then probably go for MRI. But I would say that an ultrasound is good.
I think
Is
decent
yes,
ultrasound is good enough for
good
adolescents.
enough. Yes,
That's what I
yes,
wanted to say, because directly we need not send them for an MRI when they have a pain or anything.
absolutely, absolutely.
And basically, the risk factors which I have seen is we need to have a detailed family history in these girls, adolescent
Yes.
endometriosis, where first relative or anybody is having endometriosis, they tend to have that genetic
Okay.
hereditary.
Okay. Okay.
And also the menstrual cycles, if they're shorter, longer, heavier, the literature has shown that they are more tend towards endometriosis. Shorter
Oh, okay.
cycles, longer cycles, and heavier cycles.
Okay, okay, okay. And this is in all age groups, Dr. Avani? This is
Yeah,
in all,
yes, yes,
yeah. Acha,
yes,
acha.
yes.
Okay, okay. That's nice. Yeah, that's
So, and as we all know, we have to have a detailed history and the examination. Where in adolescence it's little difficult because we have to just go on the symptoms and ultrasound diagnosis. We
yes,
can't do
yes.
a pervaginal examination.
Yes.
Yeah, yeah.
And coming to the blood markers, there are blood markers like CA125, many other markers. Also, there are genetic markers and immunological markers. So, generally, what happens in endometriosis, where it deposits, body immunity only takes care of the tissue. But in
Right.
women, where is their altered immunity, this endometriosis, the endometrial or ectopic endometrium implants and forms the fibrosis. So there are immunological markers to know which, it is really endometriosis or differentiate from the other things. And coming to the reproductive age, this is a big challenge for us when an endometriosis patient comes to us. We have to treat their symptoms. They have to conceive, and we have to take care of their emotional, psychological, everything. Already they are stressed.
Yeah, yeah.
So, generally, in reproductive age, our treatment depends on basically their ovarian reserve first. So, it depends on their AMH levels and the ovarian reserve. How long have they've been trying, how long they have been married, and the sperm factor. These factors we keep in mind when we are planning the treatment for endometriosis. If they are a younger age group with decent reserve and sperm factor is fine, first we deal with the endometriosis. Like depending upon the endometrioma, if the size is more than 3 centimeters, we would prefer a laparoscopy. If it is 3 centimeters, we would suggest them try, it's okay, you can plan your pregnancy. And the other problem which we face is the adenomyosis,
Yes.
uh, where the uterus anterior or completely it is there, or there is an adenomyoma. Here, I just wanted to ask you, how do you differentiate? Are there any differentiating features between adenomyosis and adenomyoma
So usually,
radiologically?
yeah, this again in my personal experience, I'll tell you what I have seen. So when it is a diffuse adenomyosis, the uterus is very, very globular. The shape, it is very globular and it shows intense myometrial shadowing. And the endomyometrial differentiation is very indistinct. And even subendometrially, just below the endometrial lining, whether anterior or posterior, we do see linear echogenic strands and small hypoechoic areas. We can't
Mm.
call them cysts, but there'll be multiple small hypoechoic. It's like nodularity, I would say, micronodularity. But in the case of an adenoma, in fact, that can also be a differential for fibroid also. Usually
Yes,
fibroid or
myoma.
adenoma. Yeah. For that, we usually see a focal area of altered echo texture sometimes, which might not be well defined. But in some cases, it can be a very well defined looking mass, almost mimicking a fibroid. But I would say we usually don't see myometrial shadowing in a fibroid. It is mostly seen in adenomyosis. So I think
Any
this
any role of blood flow in differentiating between the myoma and
blood flow is mixed. I mean, sometimes we see, sometimes we don't see. So I don't rely too much on that per
on
se.
the Dopplers?
Because yes, on the Doppler, yeah.
Okay, okay. So, and one more thing I wanted to ask, how should we differentiate between a hemorrhagic cyst, that's here already mentioned, Dr. Hemalatha, between an endometrioma and the malignant cyst, malignancy? Sometimes a solid malignant mass, we will be like, how to diagnose? Like, because we do the scans ourselves, I'm just asking you for, like,
True.
no, because how to differentiate? Any classic differentiating point is there?
So see here again, if I am
Yeah,
going to talk
I
out of
agree.
yeah, out of my experience in the last 9 years, I've been working as a consultant in Vijaya ever since my MD. That's 9 years. And usually, age is one factor because small endometriotic cysts and hemorrhagic cysts, we usually, like you already mentioned, Dr. Avani, either in adolescence or in like fertile reproductive age. But at the same time, when a postmenopausal or a premenopausal, or an elderly lady who's still probably menstruating, I've seen ladies menstruate even till 57,
True,
58.
true. Mm.
So in those women, if I see a cyst, even if it is 3 centimeters, but it is showing septations or echoes or vascularity, definitely it's a differential. That is when I personally ask for a CA 125. And we
Mm.
also do an abdominal scan to see if there's any minimal ascites, which is usually seen only in the later stages, like when the mass is too big. But sometimes, I don't know, maybe that's the only other thing we do is look for any thing in the abdomen. And if it is really suspicious, then an MRI. So any peritoneal deposits or any spread which is happening, which can be caught early. But otherwise, I think it is mostly CA 125 and the age which really helps. And somehow ovarian malignancies are seen. I mean, I wouldn't say they are not seen, but because dysgerminomas and all are, they don't characteristically look malignant sonologically. They can easily be
True,
taken off as a benign tumor.
true.
So yeah, it
Absolutely.
is a challenge, no doubt. Even yeah, age
That
is
is because
one.
age is a
Yeah,
fact.
yeah,
And
yeah.
we also see these solid masses in younger age group also.
Very young age group. Yeah.
Yes, very young. We won't
Even
expect
yes,
they will be.
dysgerminomas are very common in 20s, 30s. So yeah, yeah.
So that is one thing, and so we need to. It's the treatment for endometriosis is a teamwork. It's a radiological diagnosis as well as the clinician, as well as the
Yes.
surgeon who does the laparoscopy. Uh, so basically, when we get patients with endometriosis, it is divided depending upon their only ovaries involved or it is diffuse. There's a lot of classifications for endometriosis where we divide it into 1, 2, 3, and 4 depending upon deep infiltrating endometriosis is one of the most difficult treating endometriosis
Yes.
because laparoscopy also won't help. That is going to
Correct.
recur. We will do an
Correct.
adhesiolysis, everything we do, but again it's going to recur. So it becomes very difficult to counsel the patient. Recently, we had one couple. She was 34 years old with I can say grade 3 endometriosis with a big adenomyosis in the posterior wall. She had hydrosalpinx, both sides, kissing ovaries, stuck in the pelvis.
Yeah.
So it was bad.
Yeah. Yeah.
So for this kind of patients, we had checked the ovarian reserve. It was fine. So we had gone with the laparoscopy. We cleared the adhesions. We removed the both side tubes because hydrosalpinx is embryo toxic when we place the embryos. And then even the ovaries were not accessible from pelvis in the TVS because of the adhesions. They were high up,
Yes. 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 Yes.
and so we had to release all the additions and then we had to do an we in these reproductive patients we have to combine medical and surgical together. Before
Yes.
we After the surgery we had given 3 doses of GnRH agonist, and then we transferred her for her. So in a reproductive patient, it's we have to combine both. Sometimes they may not require surgery, sometimes they require both, and for the success, because of the altered immune factors, the implantation also becomes very difficult for them. And when patients have adenomyosis, there is more a little more like implantation becomes little difficult, and they have a chance of miscarriages and preterm deliveries also because of the adenomyosis. So they do uterine sparing surgery, but when they're planning conception, we do not suggest that cutting of the uterus and stitching up, because after the pregnancy they can. So one more thing I wanted to make a emphasis. Sometimes we get reports in the ultrasound telling that there are dense pelvic adhesions in the pelvic adhesions are there. My query is, how do you tell, what are the findings of that? Pelvic adhesions are there.
No, we shouldn't actually. Ideally, pelvic adhesions cannot be seen.
So I always had this doubt, like how? Is there any particular features or anything where you can
No,
say
in
that there
so
are
many years,
pelvic
I don't
adhesions?
think I have reported even one adhesion, so I can't comment on it. But honestly, I think that I don't think we can really appreciate sonologically adhesions.
Okay. Well,
I
can we do it with the MRI or
I think
CT
CT is better. CT, yes, yes,
for the pelvic adhesions?
yes, yes, yes. I think further imaging is better, not ultrasound, definitely.
No, because I see reports with the pelvic
Yeah,
adhesions.
yeah,
And you
yeah.
must have seen.
Yes, 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 yeah, yeah.
I always had a doubt, how is, like we have features for how to identify endometrioma, how to identify an hemorrhagic cyst.
Yes,
Are there
yes.
any features, like there must be something to tell that there are adhesions?
Yes, yes, yes. But honestly, I would say further imaging is what really gives a clearer
Like,
idea about adhesions, like CT or MR.
so
But
when do you
first,
get
I think
doubt?
CT is better. CT, pelvis CT also gives a lot of information.
Like, one more thing is, when do you guys get doubt? When you where because of the endometriomas or the stuck to the uterus, then we might suggest that they might have
Yes,
adhesions.
the kissing ovaries, and when they are posterior or behind the uterus, that's
Difficult
when
to.
we'll, yes, difficult to evaluate, or very high up, like probably, we are not able to see very clearly on TBS, but on ultrasound also we get it when we really, the far lateral aspects or behind the uterus is when we think probably there might be adhesions.
Yeah.
Yeah.
So, uh, anything more we need to discuss about clinical? I think clinically, first diagnosis, early diagnosis is very
Is
important,
very, very, yes,
and
yes, yes.
very important. And if you don't understand with your own scans, all the we do our scans. If you're not understanding, you have to take an expert opinion and make sure the diagnosis is there.
Correct, correct, yeah.
Not like just treating that. Okay, it'll go.
Yes, yes, yes. No, but like you said, I think one thing I have also encountered a lot with endometriosis is the recurrence. Patients get very
Yes.
bothered because they come post-operatively. They say we got it done twice, thrice, but again you're saying it's still there. So that's something I guess is a little difficult for them
No,
to.
that when we are planning a laparoscopy or when we are explaining endometriosis to a patient, it is very,
Yes,
very important that they understand the disease,
yes,
and they understand that it's going to be with them till they
yeah,
stop menstruating.
yeah. Yes, it's not something. Yeah,
Something it will go off.
yeah,
So they need to understand. First, we have to give treatment for the adolescent. Then, if they're coming in the reproductive age, we need to treat till pregnancy. After
yeah.
pregnancy, also we need to treat them because they will have symptoms of this endometriosis till they stop menstruating. They need
Yes,
to understand that.
yeah, yeah,
Most
yeah,
of
yeah.
the patients, they feel once the surgery is done, we won't get it.
Yes. Yes,
So
it's
that
like
is very.
fibroadenomas in the breast. That is again something. These things are likely to, yeah.
They
And
have a
anything else?
tendency.
Yeah,
Yeah,
sorry,
you tell
sorry.
me.
Go
Sorry.
ahead.
Yeah. Anything
Anything?
related to endometriosis, it will be there with them. That they
Yes.
need to understand. Yeah, tell me.
Anything about scar endometriosis, and I mean, how to like,
See, a scar endometriosis, we have tried medical treatment. but
Okay.
it doesn't work much.
Right.
Scar endometriosis is again excision of the endometriosis if it is paining or bothering them too much.
Right. That is the only means of.
Yes, 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 for curing scar endometriosis. Though the scar endometriosis is very rare,
It is pretty rare.
but
We've seen a couple of cases, but very rare. Nothing
rare.
compared to all these.
Yes, the most common is the endometrioma,
Yes,
ovarian endometrioma,
that's the
and
most
next
common.
is the uterus adenomyosis and combined adenomyosis and as well as ovarian
Endometriosis.
endometriosis. Yeah,
It usually tends to be bilateral, or I don't know. Sometimes we see mostly. I've seen equal number of cases where I've seen bilaterally and also just, on one side itself.
mostly it is unilateral
Okay.
most of the times,
Okay.
but when it is diffuse and grade 3 to 4, then it is
Ah,
bilateral. We see
bilateral.
that. Yeah.
Nice.
So it was a very nice presentation, Dr. Hemalatha. You have
Thank
covered
you,
all
ma'am.
the topics.
Yeah, all
Thank you.
the different variants of endometriosis.
Yeah, one more question I have uh, is like in the surgery we have staging of endometriosis after we do laparoscopy.
Right.
Like that in radiology also, do we have any staging?
No.
No.
No for endometriosis.
No, we
Okay, I think
don't have
probably
it.
we need to combine the radiology report as well as the laparoscopy and just form a
Right, right,
staging, right?
right. Yeah, yeah,
Okay.
yeah. But I agree. It was a very nice interactive session. So, anything
Okay.
else anybody would like to add or say? Nobody? Anything else, Dr. Avani, would you like to say?
No, it's I think pretty much I wanted to tell about these things, how to differentiate
Yes,
all
yes,
these things, when you should send to the radiologist. So
yes,
basically, the take-home message is diagnose fast so that the
yes,
treatment is faster,
yes, yes.
and explain and counsel the patient regarding the condition and give them
Condition.
psychological support and emotional support.
Support. Correct, correct, correct. Anything else, Dr. Hemlata, which you want
Mm.
anything? No? Then we can end the session by firstly thanking Dr. Avni. Thank you so much for your valuable time
Thank you.
and the discussion which we had. I really, really enjoyed it. And I think it's very helpful because it's very important, like you said, especially for gynecology, gynec patients who come to our department to have that confidence, and also for you to get enough information from our reports so that
Yeah.
you can, yeah, give the best treatment possible. Thank you so much.
Yeah.
Thank you so much,
Thank you so
Hemalata,
much.
again.
Thank you,
Thank you.
ma'am.
Thank you.
Thanks, everyone.